past chair of Positive Living BC. I'm your host tonight. Welcome everybody, glad you're here. Our sponsors for these events, and again for tonight, are AbbVie, Bristol Myers Squibb, Janssen, Merck, and ViiV. They all contribute and make these community forums possible by the number of people in the room. Only one of our more successful events, more numbers of people attend these things, so it's money well spent. A couple of housekeeping notes. Please turn your cell phones off, put them on vibrate. Come over, beat you on the head. No. It's very distracting to somebody up here, and it's very disrespectful, so if you could please turn them off or put them on vibrate, that would be very much appreciated. Washrooms are out to the door and off to the left. This evening, we are pleased to announce that we are also live on the internet. We're doing a webcast. We've been doing this for a while. Our uptake's been a bit slow, but we have, how many people? We've got got two people on the internet right now watching us. This helps reach the communities up in the north and in the area that normally can't be part of these things. So welcome to those that are online with us.
Awesome.
And just a note, this event is going to be recorded. We hope to take segments from all of our community forums and make them available on our website. So none of you are going to be focused, and if you wish to ask questions, first of all, we would ask that you wait until the end of the presentations. And if you could go to a microphone, or if you don't want to speak, just raise your hand and one of us will come to you, get your question from you, and voice your question for you if you don't want to have your voice even appear on the recording, okay? So that's how we do that, to keep your confidentiality. That's great, okay? So I'd like to introduce our first speaker tonight, Dr. Greg Bondi, who I started seeing, I guess, early on this year, I guess back in February, March. I needed to do something about this birth I have, and Greg was very helpful for me. He's very affable, very likable man. He's a clinical associate professor at the Medicine and Pathology at UBC. He's the director of the IDC Metabolic Clinic and associate director of the Healthy Heart Prevention Clinic at St. Paul's Hospital, both of which I've been to recently. Dr. Bondi earned his MD from the University of Toronto and did his postdoctoral training at the University of Western Ontario. His research interests include, oh my God, dyslipidemias? Did I say that right? Dyslipidemias? Something like that. Type 2 diabetes, that's an awful mouthful. Type 2 diabetes, obesity, metabolic abnormalities associated with HIV therapy. In addition to his clinical and research activities, Dr. Bondi is extensively involved in undergraduate, graduate, and resident teaching. He is the founding director, was the founding director of the Principles of Human Biology, which is taught in first-year medicine, and was co-block chair of the Endocrine and Metabolism block, which is taught in second-year medicine. Please welcome our friend, Dr. Greg Bondi.
John, for those kind words. Does everybody hear me okay?
Yes.
Actually, John has an incredibly good TV voice. Voiceovers. Wait, so I just have to get out of here. Okay, in the next 20 minutes or so, it's going to be fairly low-key. What I'd like to do is go over vascular risk in HIV. I'd like to make it practical from your standpoint, what you need to know, and some of the treatment options for you. So again, I'll just briefly go over cardiovascular risk in HIV therapy. It's an issue that continues to evolve. I'll talk about the use of biochemical markers, and then lastly I'll spend most of my time talking about the treatment. So this slide is an oldie but a goodie. It came out in 2003. It really shows the dramatic change when antivirals, specifically HAART, was introduced. As you can see in the mid-1990s, it really dramatically reduced death. I'm sure everybody in this room remembers that magical moment. On the bottom, however, as you can see, there's a flat line. That's basically vascular disease. And in the HIV cohort that they studied here, it was a relatively young cohort. It was, you know, the incidence or prevalence of heart disease was really quite low. It was only after several years of having heart therapy that it began to emerge that people were starting to develop vascular issues. And as you can see from this slide, when you compare people with HIV versus non-HIV, the risk of getting a heart attack is increased. And it's roughly increased about twofold. Okay? Now, there's a number of possible reasons for this, and we'll discuss those in a minute. It probably was related to the antivirals that were initially introduced, but it also is probably related to other risk factors, such as smoking and other traditional risk factors. And we'll talk about those. Now, the thing that's evolving is, as time goes on, certainly data from a variety of cohorts, this one listed is from the Kaiser Permanente, showing that MI rates are actually falling in people with HIV. And there's probably a number of reasons for that. A lot more people are going on statins, which is the primary way we lower cholesterol. We're also using drugs to treat HIV that are more lipid friendly or more metabolically friendly. And basically, there's been good uptake. People have recognized that people with HIV have an increased chance of having a stroke or a heart attack. So, this isn't meant to impress you about the complexity of vascular disease, but it's only meant to remind me to tell you that the development of hardening of the arteries is really a complicated process. We always talk about cholesterol, but I have to tell you there's probably 20 different factors that contribute to the development of a plaque. That includes the damage to the endothelial wall. That can occur in people who have high blood pressure. That can occur in people who smoke. That can occur in people who have ongoing infections. So there's a variety of ways that you can damage the endothelium. And then what happens is naturally enough, your body wants to repair that damaged cells. It recruits macrophages. Macrophages are inflammatory cells that basically are very good at repairing things, but they also absolutely adore cholesterol. So if you have a high level of cholesterol, those cells will gobble it up, and eventually they'll become the beginning of foam cells, which is the very beginning of an atherosclerotic plaque. So again, I don't know how much you can remember from what I just told you, but the whole bottom line here is there's multiple factors that lead to hardening of the arteries. We know a number of them. There's still work to be done to identify other risk factors. And I don't want to give you the impression that when you walk into the room and see me, that I can tell you, yeah, you're going to get a heart attack, or no, you're going to be safe. We really haven't reached that level. Okay? There's some people who have all the bad risk factors and they seem never to develop heart disease, whereas other people lead incredibly healthy lifestyles and get heart attacks for some unknown reason. That being said, when we look at people who develop, it correlates very well to traditional risk factors, and we'll look at that. So, looking at traditional risk factors, this is a complicated slide, but it is from Salim Youssef, which is one of the Canadian superstars. Actually, it's one of the world superstars. And his whole role in life is to identify different risk factors that lead to heart attacks and stroke. And he can list them both in men and women and how much they're contributing to your increased risk. Now you can see at the top is smoking. And in a man, that increases your risk about threefold. In a woman, it's about 2.9 or 2.8. You can see diabetes is also a risk factor. Hypertension, abdominal obesity, your psychosocial index. So if you're poor, basically that increases your risk of developing heart disease. And as you can see, it's almost as much as a risk factor as having diabetes or smoking, which are the traditional ones. Okay? And on the bottom is a biochemical marker. I don't have time to go over that, but basically you can stratify different populations throughout the world and identify which are the traditional risk factors. And I can tell you, we always say genetics plays a role. Well, about 80% of your risk is actually environmental, meaning it's coming from risk factors such as smoking and hypertension. So, regarding HIV itself, the DAD cohort in Europe has told us that with every passing year of being on an antiviral, your risk for developing cardiovascular disease increases. Now this is again an old slide. This is from 2003. This was using, and again this data was dating back to the mid-1990s. Now again, that included medications. We used high-dose protease inhibitors, such as Crixivan. We used other agents that had very unfavorable lipid profiles. So it wasn't too surprising that the more length of time you were on the antivirals, the more risk of getting heart disease. Now, these slopes are starting to flatten. With the newer agents, which are much more metabolically friendly, the risk associated with the antiviral therapies themselves seems to be diminishing. That being said, we still don't really know why people with HIV are at increased risk. It's probably multiple factors, and I'll show you that on the next slide. So, in terms of vascular risk with HIV, these are some of the proposed mechanisms. Top of the list is lipid abnormalities. Lipids are things like cholesterol, triglycerides, and these are fats in your blood. Now, when you look at cholesterol, you always got to remember the good and the bad. The good cholesterol is HDL. Generally, the higher your HDL, the better off you are. Okay? LDL is the bad cholesterol. The higher your LDL, the more at risk you have of getting heart disease. And I'll tell you some numbers you got to look at, but while I'm on that, basically, if your LDL is below 3.5, generally you're doing okay. Unless you have established heart disease. If you have had a heart attack or are diabetic, that LDL should be under 2. So I don't know how many of you know your numbers, but I'm in a numbers business. I look at the numbers, basically that dictates how we're going to manage things. So that's cholesterol. The other thing is people with HIV, at least initially, had a higher prevalence of abdominal obesity. Again, body fat redistribution. So people would get abdominal fat in their gut, and by doing so, that would put you at increased risk for heart disease. Because when you put fat around your gut, it increases your chances of diabetes, it increases inflammation. Very interesting. You can plot markers of inflammation, and I'll tell you about those in a minute. The bigger your gut, the higher your CRP will be. Conversely, if you lose weight, your CRP inevitably gets better. Insulin resistance. As the name implies, your body makes insulin, but doesn't work very well. And again, that's generally related to your body weight, especially in the belly. And that is one of the risk factors for getting diabetes and heart disease. Inflammation. And basically, if you take people with HIV and you looked at their arteries, and that's what endothelial dysfunction means, inevitably, at least in the early days, it would be abnormal. And that was probably due to a variety of different factors that are listed. So, we know some things, some of the traditional risk factors. I'm fond of using biochemical markers to stratify individuals. The two that I use primarily are one's called ApoB and one called CRP. I'll tell you what they are on the following slides. ApoB is a marker that I like to use Basically because you can measure it in people who are not fasting, which is a big important advantage. It also can be measured in people who have high triglycerides. People with HIV who are on antivirals tended to have high triglycerides, and because of that, you couldn't measure their LDL reliably. So ApoB is actually very useful to measure in people who are on antivirals, who have HIV, and basically you can't get a reliable LDL measurement. The key number to remember here is you'd like to see an ApoB under 0.8. If you're above that, you got things that you have to worry about. Again, that's the main advantage to ApoB is non-fasting, and you can measure it in hypertriglyceridemia states. So, the other thing that's become quite apparent is HIV is an inflammatory condition. And we've learned over the years that people who have increased inflammation, such as people with rheumatoid arthritis, people with Crohn's disease, these are all conditions that tend to raise inflammation. Those people all have increased risk of getting heart attacks or stroke. And basically, the way you can measure inflammation is to use a protein marker called CRP. It basically measures the amount of inflammation in your blood vessels. That being said, there are other things that can raise CRP. If you have an infection, if you have untreated HIV, your CRP will be elevated. So when I say it's useful for vascular assessment, it's in people who have well-treated HIV, and you're trying to find out, are their blood vessels inflamed, do they have ongoing issues? So, that's enough science. Basically, I'm actually very much like a witch doctor at the same time. And that's what this slide is meant to show you. That's a holy witch doctor. And basically, in his community, he's very well respected and does a very good job. So, how do you go about treating HIV at high vascular risk? Well, there's a tool that we use called the Framingham tables. Now, Framingham tables were developed in the United States, so there's limitations. We're in a population in Massachusetts, was predominantly Anglo-Saxon, so again, and Northern European. That being said, they know, as they followed those individuals, they knew exactly which risk factors put those people at risk for heart disease, and they could plug these numbers in. So they followed these people for 30, 40 years, and they could identify, using different risk stratifiers, what put you at risk for heart disease. So how do you do a Framingham score? Well, basically, you can go on the internet, you can pull out a number of tools, but what you do is you just plug in your age, you plug in your blood pressure, you plug in your cholesterol levels. You can also put in your family history, and basically it will calculate your risk of having an MI in the next 10 years. So it's a very useful technique. It allows you to get an objective assessment of that person's individual vascular risk. Now, people with established heart disease, people who've already had a heart attack or a stroke, we don't use Framingham tables because their risk is already high. People who have diabetes are at risk. Now, it's very interesting. The Canadian guidelines are quite unique in that they've recognized that HIV is an inflammatory condition, and that increases your risk. So the way they handle that is they say, okay, you calculate your Framingham score, and then if you have HIV, you basically double your score. So if the score came out saying your risk for heart disease in 10 years was 10%, the fact that you had HIV would double it, it goes to 20%. So why is it important to do that? Well, it establishes what your lipid goals are, what your treatment targets are going to be. If you are at high risk, we drive your LDL down very low. We like to get your LDL down below 2. Generally, we use lifestyle and we use medications to do that. And if you've had a heart attack, you've had a stroke, inevitably you have to take a cocktail. That includes a statin. That includes a drug called a beta blocker, which slows your heart down. It includes an ACE inhibitor, which is a drug that, again, affects the hormones that regulate the heart. And then you take aspirin. And by going on that cocktail, you can reduce your chances of having another heart attack by about 80%. It's been very clearly shown and very extensively studied. So the argument's always been, is this a good diet or is this a bad diet? And it's interesting, the reason I put that up there is there's eggs on here. And basically the whites of eggs are generally good for you because they're nice sites of protein. The yolks do contain a high amount of cholesterol. But I'll just tell you, diet is important, but it has limits with regards to managing your cholesterol. If you look at your circulating cholesterol, in general, about 80% is coming from the liver. Only 20% is what you eat. That being said, body weight is a separate issue. If you gain weight, that tends to make your blood sugars up, tends to make your cholesterol go up. And I've always seen some dramatic improvements in people who lose weight with regards to lowering sugars, lowering their cholesterol. Okay. So again, diet becomes complicated. That's why I like to use dietitians. And they can go over your diet with a fine-tooth comb. I think a lot of individuals here have done that. And it's a very useful process to go through. Okay. Now, smoking is a really big risk factor in HIV. Okay, so basically, there's far too many people with HIV who smoke. Okay, if you look at various cohorts, certainly in the United States, some of the cohorts show that up to 60% of people with HIV also smoke. So, and as I showed you, it increases your chances of having a heart attack or stroke almost fourfold. So you can see how the story's building. If you smoke, if you have HIV, if you have high cholesterol, this is all making you a sitting duck to get heart disease. What do you do about it? Well, you got to start eliminating those risk factors. You got to get people to get off smokes. You got to get people to eat better. You got to get people to lose weight. And basically, you add drugs on top to hopefully maximize your protection. And there's a number of strategies to get people off cigarettes. It's a very tough addiction. And again, there's a variety of psychological approaches and pharmacological. So again, that's why when you do lifestyle changes, usually it's very helpful to have multiple members doing it. And I think that's one of the major roles that positive living can do, is give you resources to help you get a better handle on how to improve your lifestyle and hopefully reduce your vascular risk. Certainly at the hospital, we have programs like the Healthy Heart Program, where we have exercise people, we have dietitians, we have nurse educators who basically can give you the tools so that you can get a better handle on what's needed to improve your heart. So just very briefly, I'm going to talk about medications. Now, fibrates I used to use a lot more in the early phases of the treatment of HIV. Fibrates are used to lower triglycerides. That's really all they are used for currently. When your triglycerides get above 10, the main concern is your risk of getting a condition called pancreatitis. Pancreatitis is very severe abdominal pain, and it can kill you. So that's why when your trigs are above 10, I inevitably will put you on a medication like this. In terms of lowering or reducing your risk of heart disease, statins is the main way we lower cholesterol. And when you have people on antivirals, the physician basically has to have a knowledge of different drug interactions. And I can tell you a lot of cardiologists are not comfortable with this because they're not used to antivirals. So some of the commonly used drugs used in medicine, including simvastatin, cannot be used on people on ritonavir-based regimes. The other ones, such as rosuvastatin, atorvastatin, you have to reduce the dose because drugs like ritonavir inhibit the enzymes that normally metabolize these drugs, and it can raise the level in the blood. So the main way we handle that is we reduce the dose, and you have to monitor people. They just can't go off and not be followed. There is some, certainly in my work, we found that people with HIV appear to be somewhat resistant to the effects of lipid-lowering medication. That's shown on this next slide. This is, again, the main one you could focus on is LDL. And as you can see, when you add a statin, in this case rosuvastatin, it lowers your cholesterol around 30%. Now I can tell you in a non-HIV population, if I put you on rosuvastatin, it would drop you about 50%. And why this happens still remains to be determined. But again, the story there is people with HIV don't appear to have as much of a lipid-lowering effect when they go on most of the statins used currently. So what we need is we really need trials in people with HIV to examine this. The only problem is it's very difficult to do trials currently. Again, most people don't want to be in placebo-blinded trials. And the other thing is in vascular biology, no one's doing trials with statins anymore because it's a very mature market. They have a large number of trials that basically have looked at various conditions, and all of the drugs have gone generic. So in terms of a large trial to answer this question, I don't see it happening in the near future. There is one going on in the United States using a drug called pitavastatin, which is a statin not available in Canada, and it's also a relatively small study. It's not going to tell us that does it actually prevent heart problems. So, who recognizes these guys? The Three Stooges. Yes. Who's the guy with his head on the anvil? Shep. Very good. We got a ringer in the crowd. Who's the guy with the hammer? Cole. Very good. Who's the guy with the hair? Curly. Oh, everybody gets that wrong.
It's Larry.
Oh, Larry. Very good.
Yeah.
So that's the only thing you guys are going to remember tonight. Actually, where is Curly?
He's getting his hair cut.
Yeah, he's not there. Actually, Curly's gone on to his maker. Basically, Shemp replaced him in the trio. Okay, cardiac imaging. CT angiography is a technique that you're starting to see a lot more people are having this procedure done. In the last couple of years, I've seen a virtual explosion. You'll see a cardiologist, inevitably they'll order a CT angio. And the reason they're doing that is it gives fairly high quality pictures of the arteries of your heart. Now, you used to have to do an angiogram. An angiogram is where they have to put a tube in your groin and then squirt dye, and then they can visualize the arteries in your heart. It's very invasive. Okay? It's not a fun procedure to go through. If you do a CT angio and it shows that the arteries are clear, you don't need to go through this procedure. So there's a lot more use of this technique. It's certainly very useful in people who are at moderate risk for heart disease. So you're wondering, in this person, do they have anything that would suggest hardening of the arteries? This is a good technique to use. They've also been using it in people with HIV. And it's a way of directly visualizing the arteries. Again, this is the type of pictures you get. This is a bit fuzzy, but basically that's your coronary arteries. And coronary CT will tell us, is there any narrowing or is there any plaque that's building up in these arteries? Now, this technique can take about 9 months before you get it. Okay? It also costs about $700 or so, so it's expensive, it takes a while, and it is exposing you to radiation. The technique that I use primarily to screen people for plaque is a technique called carotid ultrasound. Basically, your carotid arteries are the ones that are in your neck, and we can use ultrasound, which is not radiation, to look at those arteries. And the information I'm looking for is, do you have any plaque buildup in your arteries? Because if you see plaque buildup in your arteries here, inevitably that correlates with plaque buildup in your heart arteries. And it's a very well validated technique. As this slide shows, if you have a normal carotid IMT, your risk of getting heart disease is relatively low, whereas as you start to get plaque or stenosis, which is narrowing, your risk for getting an MI goes up exponentially. So it's a good way to find out, are you developing hardening of the arteries, and should we be more aggressively managing your risk factors? So this is my last slide. I'll give you a fairly detailed preamble. Basically, I hope I convinced you that when you have HIV, your risk for getting heart disease is increased. It's almost double. There's a number of factors why that's happening. In terms of additional biochemical markers, ApoB gives us a very good index of what's going on with your lipids. CRP tells me if you have inflammation going on. In terms of treating HIV, lifestyle is a very important component. So you've got to eat better, get to your ideal body weight, do regular exercise. If you're at high risk, inevitably we have to use lipid-lowering medications. And when you do that, you got to have knowledge of drug interactions. So that's the end of the formal presentation. What I'd like to do now is open it up for questions.
Actually, we're going to wait to the end.
To the end?
Yeah.
Yeah, if we could. Yeah, we've got a couple more people from us, Greg. So.
Okay.
I think we can agree that Dr. Bondi's got quite the wealth of knowledge, and I was able to benefit from his expertise recently. And ApoB and CRP are acronyms, unfortunately, I've become familiar with. So thank you very much for your informative look at HIV and cardiovascular health. Dr. Bondi is going to be sticking around, I hope, till the end of the evening to ask questions. Absolutely, thank you. Before I introduce our next star speaker of the evening, I want to welcome Michelle and Christina from the Community Health Initiatives of the UBC, Community Health Initiatives of University Students at UBC. That's a bit of a mouthful, girl. To talk about an upcoming cardiovascular event that's going to be offered at Positive Living BC. Michelle, Christina.
Hey everyone, my name is Christina. I'm a first-year medical student at UBC.
And my name is Michelle. I'm a first-year pharmacy student at UBC. And we're in the CHI, it's just called a CHI, the Community Health Initiative by University Students, which is a group of volunteer students whose mission is to provide health education for a variety of social groups for free. So we're having a Healthy Heart workshop on Wednesday, October 29th from 6 p.m. to 8 p.m. at Positive Living in the boardrooms and offices. And it's open to all members, staff, and volunteers of Positive Living BC.
So at this workshop, you'll be hearing a lot more about what you just learned today. You'll be learning about the signs and symptoms of cardiovascular disease. You'll be learning about how to reduce your risk. You'll be learning about nutrition as well, and some exercises, all from different students at UBC. So there's medicine, pharmacy, and we also have dietetics and kinesiology representing. So if you want to join this awesome workshop, I should say there will be food. We'll be serving you dinner. You can contact Jonathan. So at the center of your table, there's a summary of everything we talked about today, and his contact information is at the bottom. So you can just shoot him an email is probably best. Thank you.
So again, October the 29th, it's a week tomorrow, 2 weeks tomorrow, right, I believe, yeah, just before Halloween. Excellent. At 1107 Seymour Street. Jonathan's right here, but his contact information is on our forms. So at this time, I'm going to introduce somebody that many of you will be very familiar with. She absolutely is an amazing woman. She just recently was married. I gave it away. Denise Becker, now Denise Wozniak. Denise has been a role model in all she does. I had the delight of serving on our board of directors for a number of years with Denise, and it was absolutely a pleasure. Denise has had a very long story. She's been infected with HIV since 1989. She discovered her diagnosis at the same time as that of her baby daughter in 1994. 3 months later, her daughter died. Denise then went on and took that tragedy and used it to form the Hummingbirds Kids Society for children infected and affected by HIV and AIDS. And that society is still going today. Quite a legacy to leave behind, kiddo. She became an advocate locally and internationally on TV, radio, print media, and has spoken at many conferences. Most recently, Denise has become the North American representative for the international community on women living with HIV and AIDS. That is quite an accomplishment. She's also been awarded the Gold and Diamond Queen Elizabeth Jubilee medals for her work, and she recently won a fashion shoe award at the AIDS Walk for Life. This girl knows how to dress and put on shoes, let me tell you. So anyway, without further ado, Denise has always had a struggle like many of us with HIV, and you'd never know to look at her today. She's absolutely fabulous, but here she is to talk about the struggle and the solutions that Denise has found that work for her. Denise.
Amazing introduction. I really hope I can live up to that. I'm just going to find it to my talk here. Okay, it's on the tabletop there. I don't have a lot of slides. Basically, they're all of me. This one right here. Yeah, that's it. Thank you. All right, and yeah, hooray. Well, my name's Denise Wozniak, and as some of you may be able to tell, I have a little bit of a different accent. I'm from England, which right away tells you that my food health has not been that good. If any of you know English food, you'll know I was doomed from the start.
Fish and chips.
What happened was that I grew up in England, and I'll show you a quick picture of me when I was little. That's me refusing to eat the apple on the steps with my brother and our 2 friends. I was the little fat girl. I was fat for quite a long time because my mother used to love to bribe me with candy. And in addition to that, we all know that you can't live in England without fish and chips. I loved fish and chips. It was my favorite meal. In fact, the favorite meal I had was chip butties. I don't know if anybody knows what a chip butty is. Okay, you gotta try one. It's white bread with butter slapped on it, and you put the French fries in the middle, and you turn it over and make a sandwich. It is fantastic. It's really good, honestly. And sometimes you can put ketchup in there too. It's pretty good. Anyway, I grew up with this kind of meal going on in my life. And of course, we had to soak everything in fat to make it good. We had fried tomatoes. We had fried bread for breakfast. And I think it was only the fact that we exercised so much in England that really got us so that we did not become really, really fat. When I was young, I used to play field hockey, and of course, every child in every playground played soccer. So, but at the age of 10, I was playing soccer, and I started to lose weight because I was exercising so much. After that, I started to cycle a lot. I cycled everywhere. And I would bike to my first job, which was 3 miles each way. But I loved it. I loved cycling. On the weekend, I'd go out cycling. And I was from not a wealthy family, but middle of the road. So I never really wanted much for food. After a while, my parents broke up. And my mom, originally from Canada, came back to Canada. At that point in my life, I decided to go to Canada too. And I discovered what a real steak looks like. I couldn't believe when I went to Calgary and went to the Ranchman's and they served a steak. I could not believe my eyes. It was the most incredible thing I'd ever seen. We were also eating potatoes. I was eating more vegetables, and this time they weren't soggy vegetables. They were actually cooked pretty nicely. They were nice and crisp. But unfortunately, it was a period in my life when I became pretty depressed. I'd had a couple of different boyfriends. My husband told me he had cheated on me. After that, the man I was with left me, and I really felt it was my body image that was the problem. And so what I did was started to look at magazines, and in all the magazines you see women looking nice and skinny. And I knew if I could just get skinny, I'd look better. And of course, Princess Diana at the time was looking fantastic. I remember standing out on Nelson when she came to Expo in 1986 and watching her go by, and I thought, oh, she looks so fantastic. Little did I know the reason that she looked so fantastic. It was the reason that I started to look fantastic at that age too. The reason was bulimia. That came into my life one day when I had a lot to eat and I threw up afterwards. I'd had too much to eat. And to my surprise, the next morning, it was kind of a nice surprise. I'd lost quite a few pounds. And I thought, oh, this is interesting. So I can eat a lot and then throw up later, and I actually lose weight, and I don't get hungry. Oops. This was me in 1989. I put this picture up on my Facebook the other day, the one on the right. The picture of me on the right was at a Christmas party for Ernst & Young. The other picture is of me at work. And the interesting thing is that when I put that picture up on the right, I had over 50 people say how much they liked the photograph. What they didn't realize was that I was being sick every single day to look like that. I made sure every single meal I went out afterwards and threw up. So when people told me I looked good, I knew that I had to keep doing it. That was the thing that was going to get me noticed. Men looked more at me, and I just felt like it was the right thing to do. And it was only Princess Diana finally coming out and saying that she had bulimia that maybe I shouldn't be doing this. It actually was a turning point in my life when she did that. By that time, 1989, I had such low self-esteem, obviously, because I cared about what men thought I should look like. And in that year, that's when I got HIV. I was with a boyfriend who I'd been out with for a few months, and up until that time, I was married for 8 years, had only been with one man. At that point, I was with a boyfriend, and he passed on HIV to me. How do I know that? Because I never had a blood transfusion, I didn't ever do drugs, and there was only one other way I could have got HIV, and that was through having sex. Never know, I don't know where that man is now. He's gone out of my life, but I gave in his name to the Center for Disease Control here in BC. I didn't know at that time that I had HIV. As John said, I found that out 5 years later when I was married. And that was one incredible shock, I can tell you. Because my daughter was in hospital for pneumonia, and they told me at that time that they were going to test her for viruses or bacteria, what could it be, and they actually tried to get me to come down to the hospital. Any of you that know Dr. Burge or Dr. Forbes had me come down to the hospital and he said, we've got some bad news. And at that time I found out that my daughter had AIDS and that I had HIV. They had to do more tests and I had to wait a week just to find out that that was true because they didn't have the rapid tests that they have now. At that point in time, 1994, I was told, well, I might live 5 years, which seemed pretty good to me. And I thought, wow, I'm going to eat all that I can. I'm going to eat cake, I'm going to eat everything. But unfortunately, I had very bad diarrhea, so I couldn't put on weight as I thought I could. In 1996, we had the AIDS conference in Vancouver, and that was when we got the incredible news that we were going to live longer, and it was just so amazing because we looked at each other and thought, what are we going to do now? Okay, if we're going to live, what does that mean? Well, for me, it meant that I was going to eat as much as I could. And I'm going to show you this picture of me on the left. That was last year, and interestingly enough, I was hardly eating anything in that picture. And the reason I had put on so much weight was because I was incredibly poor at the time. I was actually hardly getting by at all. I was renting a house, and so every time I got, say, $6, I'd go to McDonald's and buy a burger because I knew I couldn't afford $20 at the grocery store, let's say. And what that did was spike my glucose levels and then brought them crashing down afterwards, after I'd had that burger. And when I got to the bottom, I was starving hungry again. But then I had to wait a long time to the next meal again. And so I was going through a bad time with coming way up in glucose, coming way down in glucose. And I did not realize how to stop that. I didn't know how to eat well. And what I found out later on was that white bread was very bad for me. I found out that potatoes were bad for me. White rice was bad for me. I found out that spaghetti was bad for me. Pretty much everything I loved was bad for me. Snickers bars, I ate those all the time. Couldn't eat a Snickers bar anymore. And so I started to look into what was good for me. And I moved down to Vancouver, met up with my incredible partner, Henry, and I actually went in to see Dr. Bondi. And Dr. Bondi was looking at my cholesterol levels, my triglycerides. And this was actually in February of this year. And Dr. Bondi said to me, you have to lose, I think you said 15 pounds, which, around about 15 pounds I think it was. And he was saying to me that you really want to try and get your LDL down, correct? I always remember this because HDL, H is high five, and LDL is down low, not so good. So HDL down, and my triglycerides were bad. So I went away, and I knew I wasn't going to exercise because I was heavy. I didn't feel like exercising. And then besides that, I lived out in Mission in the country. And so I knew I couldn't exercise because I knew there were just about 10 or 15 bears out there waiting for me. And I am scared stiff of bears. Henry will tell you, I can't even take the dog for a walk because I am so scared of running into a bear. I'm trying to conquer it. Anyway, at that point in time, 2013, I was riding my bike 3 times a day. That was pretty good. I was getting lots of exercise, but I wasn't eating well. So I was at Henry's and I started to eat much better. I started to have sunflower seeds. I ate tomatoes. I ate avocados. I started to eat good protein. And I stopped eating all the complex carbohydrates. And if you want to know which is the bad food, everybody's heard it's on the inside aisles of the grocery store. So if you go to the frozen food section, that's where it is. I know because that's where I get my pastry shells. That's That's one thing I found hard to give up. Eventually, I lost, I think it was about 13 pounds, and I feel so much better today. I changed my breakfast. Now I have shakes in the morning that I actually buy these shakes from a company, and they give me good vitamins and supplements, but they also are easy for me to make. So in the morning, I make the shake, and I'm done in 5 minutes. In that shake, I put in kale, or I put in spinach, and I put sunflower seeds, and I have been putting in blueberries when they were in season, but now I put in coconut milk. I've totally stopped having milk because I didn't want the cholesterol. I didn't have any more juice because I knew there was a lot of sugar in juice. So I had coconut milk, or I could have almond milk. I just preferred coconut milk. The reason that I changed my diet and was very hesitant to go onto lipid drugs was because I am so allergic to medication. I've been on the same meds now for about 4 years, but quite a long time ago, when they were bringing in all the different medications, at first I was on about 24 pills a day. As time went on, that became less and less and less, and now I'm on 3 pills a day. But where I've had a problem is that, as I said, I've had very bad reactions. So the first reaction I got was Stevens-Johnson syndrome. If anybody knows what Stevens-Johnson syndrome is, you get a very bad rash and it's life-threatening. Now, Julio Montana told me, you may get a bit of a rash. If it gets worse, get to hospital. Well, I felt a rash coming on that night. I felt itchy. And I looked in the mirror and I thought, oh, not too bad. So I went to bed. I woke up, my whites of my eyeballs were red. That's how much of a rash I had. I was like a light bulb. I went and looked it up on the internet. Of course, I didn't go to the hospital. I had to Google it first. And I thought, is this what I've got? I'm looking through the pictures. Yeah, I think it's what I've got. And then my husband said to me, he said, what are you doing? I said, I think I've got this thing. And he turned on the light. He said, oh my God. And so he said, come on, let's go to hospital. So we went down there and they put me on a drip, and I was good afterwards. Another thing I got was apparently you can get psychotic from a couple of drugs. Now, I didn't notice this myself, but a lot of people around me apparently were phoning Dr. Montana and saying, you've got to get her off that drug. I felt very empowered for once in my life. But they said, no, you've got to get her off the drug. So what's the difference that the food has made to me majorly is that I don't have any pins and needles in my hands anymore, or my legs. I'm on antioxidants, which have made a big difference to me. I'm also on antidepressants, and they have made me very tired. But I've started taking something called ubiquinol and CoQ10, and that has given me a lot of energy. So it's counteracted how tired I've been getting with my antidepressants and with my anti-anxiety pills. What the future holds, I've got to find out what exactly the future holds, but I'm pretty positive about it, and I think every day I try and be thankful because I know I have things that people in Africa don't have. And I'm not talking about Ebola, but I have things that other people don't have. I have medication right now, and how thankful am I for that? You know, when you see people over there still dying, it's very sad. And I have the opportunity to have good food now that I'm with Henry, and it makes so much difference to my life. And I'm going to stick around afterwards and take any questions that you want. I'm finding out about glycemia, so I'm not an expert on it at all, but I know that it makes a difference to the amount of inflammation in your arteries. And I'd like to hand it back to John.
This is all very interesting and all very timely. I sort of alluded to the fact that I have been through a few of these things myself. And indeed, I was through the Healthy Heart Program. My triglycerides are still through the roof, although I'm on medication for them. My LDL and HDL are back where they should be. They're in better ranges, and all the other factors, my blood sugar is better. But it was through the good work of people like Dr. Bondi, it was through the good work of my own GP, Dr. Paul Gross, and through me making absolute baseline lifestyle changes. It meant giving up the Minute Maid lemonade, which was my favorite drink. It's probably about 30% sugar. Really bad for me. So it really is, you need to be proactive with your doctor. You need to get engaged in a conversation with them about what is best for you. Be proactive in making sure that all of your medications and all of your blood serum levels are taken every 3 months. I hate my fasting blood sugar tests. Fortunately, I'm able to do them only every 6 months now instead of every 3 months, which is a little bit better. But it's not something that's convenient. It's a real pain in the backside, to be honest with you. And when you're getting already a couple or 3 needles a month, or every 3 months for HIV, and then they add another half a dozen on for all the other things that they want to give you, it doesn't become a fun game anymore. Anyway, we have a microphone situated in the middle of the room. If you wish, you can proceed to that microphone, or we'll have our questions answered by Greg and Denise.
Can the microphone come to us?
It can come to, yes, I can bring the microphone to you. Sure. Mohammed, the mountain will come to you.
Yeah, okay, I have a few questions for Dr. Bondi. First of all, Dr. Bondi is one of my doctors, and thanks to Dr. Bondi to get me into the metabolic program. Kind of saved my life and changed my lifestyle, actually. So, and that's what I want to talk about, because we've talked a lot about losing weight. And I remember that when I joined that program, for me, the exercise program worked well, but also the nutrition was a help. But losing 20 pounds was not a big deal for me. What made me really proud was losing 1.25 inches of my waist. And that really made me so happy, because I was going to throw all my clothes because it didn't fit, but now I was able to get back into the clothes I was wearing, and I was feeling good about myself just by the 1.25 inches waist that I'd lost, not the 20 pounds that I had lost. So what is the importance of exercise for HIV men and cardiovascular?
Mike Schlepper.
And the other thing is, why is not a program of this sort that was a type trial for a year for HIV men or women?
Okay, so a number of important issues you brought up. So exercise is a really big component in treating metabolic disorders. It's probably